The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everybody. This is Michael Flora with MTM Services. It's a pleasure to be with you today as we develop our webinar for this afternoon, Productivity Management in the New Value-Based Environment. So one of the things that I've been thinking about recently is there's a myth going around that in the new value-based or prospective payment environment, that productivity no longer is needed, that we'll be paid on our outcomes. Now, it's clear that we're moving from volume to value. So rather than the fee for service or other types of contracting, without a clear understanding of the direct needs to achieve the needed outcome in an alternative payment environment, organizations will not be able to assess their costs for an episode of care or level of care. So today's webinar will focus on the key aspects of productivity and direct service needed to support value-based payment. We're going to learn the key distractors and enhancers of productivity in the value-based environment and develop kind of some standard operating procedures around our episodes of care and best practices. Several years ago, I developed the 9 core competencies needed in a new behavioral health care environment. These 9 competencies include access, intake, and consumer scheduling. So moving to same-day access or just-in-time prescriber scheduling, but also being able to move away from just having a schedule to managing a schedule. And we'll talk more about that as we develop backfill, will call, schedule management protocols. Information and medical records management, our ability to share information across our care partners and team-based care environment. Workforce engagement and human resource management, so thinking about those HR perspectives, recruitment, retention, helping our team members be successful, eliminating barriers. Billing and financial management and cost containment, so our revenue cycle, failed claims, denied claims, bad debt write-offs, by reason code, by staff member, by program. Strategic business planning and financial viability in that value-based environment. Risk and safety management. Continued quality improvement and compliance. So utilization management, utilization review. Outreach and awareness, governance and leadership. All of this team centered around outcomes. Can we demonstrate that individuals are getting better? Can we demonstrate that we're meeting our contractual obligations? See, what's changed? See, organizations have been operating successfully in many states for over 58 years. See, the increase in the number of financially troubled organizations has provided a growing awareness that there are hopefully some internal factors that can be addressed to favorably change these dramatic financial status shifts. So over the last several years, we've seen obviously new money being poured into organizations through COVID relief or other funding. But prior to that, there was a great increase in the number of financially troubled organizations where they're no longer making margin or covering their costs. So organizations will need to begin to focus on those external factors to solve their needs. Several predictive core internal performance improvement service delivery indicators are starting to surface, and we're going to talk about those today. See, the service delivery system indicators is first the absence of revenue focus by clinical staff and support staff for earned billable hour revenue and proactive collections of consumer fees and accounts receivable. So we're both admin and clinical staff are working towards that revenue focus. There's also a lack of clearly defined clinical and non-clinical performance standards, performance-based job descriptions and functioning toward those accountability measures. The ability to measure and demonstrate compliance with clinical and non-clinical performance standards. Alternatively, integrating non-compliant behavior, aptitude, and attitude into a proactive accountability model, and providing services in the absence of integrated utilization management plan that most always results in cost of service being higher than the net revenue received. There's also a lack of awareness of the cost of individual service and net revenue. What does it really cost you by CPT, HCPCS, and provider type? What's my net revenue after failed claims, write-off, bad debt? The inability to measure and maximize practice variance between clinical staff by service code. The lack of average length of best practice models, length of service. So especially in an episode of care or value-based environment, what is the appropriate dosing of services that are needed to achieve the appropriate outcome? There's an inability to measure reduced no-shows to the best practice standard of 0 for no-shows for intake for same-day access and less than 10% for continuing appointments. There's a narrower definition of quality improvement within organizations that I've seen over the last several years, where we're not embracing or fully integrating corporate compliance, costs, and effectiveness in utilization management in the definition of quality. And obviously a lack of the use of evidence-based practices. How do we know that staff are meeting the fidelity model and are competent? Supervisors are facilitating ongoing discussions about how staff cannot achieve their goals or exceed standards, especially over the last several years, where managers and supervisors and leadership may feel reluctant to hold staff accountable. Well, if I hold them accountable, they will leave, is what we tend to hear quite a bit lately. Service delivery systems that are actually loosely held federations of private practices or silos within their organization. Multiple documentation process that slows our staff down. And the lack of self-actualizing management data report, the true data-driven decision-making. So without the use of an integrated performance improvement plan that incorporates solutions in all the identified clinical and non-clinical practice concerns, organizations will continue to make important and clinical and financial operations decisions in isolation of each other, rather than as fully integrated process. So our goal today is to kind of dispel the myth that direct service volume no longer matters. It matters because it has an impact of our cost, because these isolated decisions are more contextually challenged by the distinct absence of clinical performance indicators and data, particularly in light of the requirements to comply with external standards and regulations. I'm reminded of a team that moved from their fee-for-service environment to prospective payment or an alternative payment methodology over the last several years. Previously, under the fee-for-service model, there was an expectation that their clinical team members would provide at least 26 direct service hours a week, 113 a month, 1352 a year. When they moved to a value-based environment, they changed the definition and said that instead of 26 direct service hours, we're going to require that you have at least 26 events of service a month, with no definition of what an event of service might look like. And what they found was that staff were spending on average 26 events, absolutely, but those average events were between 5 and 10 minutes in length. So staff were spending about 4.5 hours a week in direct care, as opposed to 26 hours in direct care. What do you think that did to their cost? It increased the cost substantially because I have a lesser number of direct service events to spread my cost over. So we want to implement that sustaining performance in the new value-based environment. Ongoing monitoring and evaluation of the quality metrics, including direct service, are going to be necessary. And we need the ability to objectively measure that performance. So in that nutshell, in the value-based payment environment, client engagement will be the key element in collecting the quality measures and meeting the contractual deliverables in value-based payment. That client engagement is their actual participation in the appropriate dosing in that episode of care. So how many hours of case management, how many hours of direct individual psychotherapy or med management will I have? What's the appropriate level of care to achieve the appropriate designated clinical outcome? So the question is, do you know your current consumer engagement rate? Clinic-wide engagement rate, counselor-specific engagement rate, or the no-show rate? See, the engagement rate is just the opposite of no-show. It's their actual participation. So it's the total number of weeks consumers remained in treatment divided by the total number of consumers identified. So to determine your engagement rate, for each client who entered treatment during the period under consideration, determine how long that client remained in treatment. It's important to select an objective measure for active treatment. So that's where you would define that, such as attended at least one or more treatment sessions in 2 weeks. For each client admitted during the time period under study, calculate the number of weeks in treatment. Then you want to add the number of weeks the client remained in treatment and divide that by the total number of clients admitted. That gives you an engagement rate. And we want to see that probably in the 80th, 90th percentile of total engagement, which means they're getting value. They're the ones getting value. Remember, value is determined if we can achieve the same or better service outcome with a change in service delivered or a change in process cost, which makes it a better value for the payer and ultimately the individual served. So are we prepared to incorporate the plan for the new value-based environment that successfully brings together volume and value? Being prepared, however, is only part of what is needed to establish meaningful partnerships. Successful organizations will have the strategic marketing, negotiation, relationship skills. In addition, the new model will organizations to be more agile in responding to the constant changes and chaos in an ever-changing environment. One of the things I've noticed, though, see, if I have several people have the problem, it's more likely sort of a systemic or management problem within the organization. See, if one person has a problem, that's an individual. But if more than one individual has the problem, that's the issue. So if one person has a challenge meeting expectation, that's an individual challenge. If I've got a whole team that's not meeting goal, that's a management problem. See, the problem of motivating teams to peak performance is a matter of lack of reinforcement. When you don't get enough reinforcement for what you're doing, your attention waters, and so does our team's performance. So improving performance and providing value, provider organizations must be able to demonstrate appropriate direct service utilization and impact of care. So I've even seen teams over the last several months and years kind of change the wording. So we're not calling it productivity, we're maybe calling it a direct service ratio, a utilization ratio, or impact. Provider organizations must be able to produce measurable outcomes and objectively show the effectiveness of their services, that their consumers are actually getting better out of the combined service array, frequency and duration provided, that the cost of treatment is positively impacted by outcomes achieved. So if I'm entering into a value-based or prospective payment environment, I'm going to get X number of dollars for every episode or unique daily visit that we provide. Based on the dosing of those services, are we making or losing money on that episode of care? See, the measurable outcomes produce the desired healthcare value that drives the quality of services that are provided and keeps the cost of care in balance to maintain the organization's financial viability. The primary challenge facing healthcare providers is achieving the need for core competencies to be that viable partner with payers and managed care organizations. So without the competencies in those 9 critical areas that I outlined up at the beginning of our service today, the cornerstones of value and demonstrated measurable outcomes cannot be achieved. So healthcare values the quality of service over the cost of the care. The lower the volume, the higher the cost. So when we base our measures of performance They're based on years of experience in working with organizations just like yours across the country. These are created from a combination of best practices that are seen, developed, and implemented at high-performing organizations, as well as an alignment of various accrediting and regulatory bodies. MTM pays very close attention to state and federal regulations, as well as accrediting agencies, and develops measures that align with these standards. So you'll hear throughout this webinar the distinction between best and good may vary depending on the metric that we're using at, but generally good is what will pass regulations or accreditation or keep the organization financially and clinically strong, but also still having a next level to strive for, best. As mentioned in the action, baseline measures are the minimum in our expectations and can be considered the must-do expectations. So best practice measures are set at 100% to ensure that the reference standard happens all the time for fundamental elements such as corporate compliance and safety. The provider organization's goal is to strive for excellence with every measure. Variance from the standard should be an area of continued performance improvement or review. Anything less than best practice measures should be the object of an internal performance improvement planning. What do we need to do to move it from good to best? What are the systemic or individual challenges in meeting those expectations? And review the standards against the internal measures of success, contractual obligations, key performance indicators, or dosing within an episode of care. Metrics at anything less than 100% are based on the usual and customary best practice standards within the industry. Should the organization choose to measure less than best practice, we do recommend that management seek the advice of written opinion of legal counsel, corporate compliance, or the organization's insurance carrier. So today we're going to think about baseline to good to best. Baseline outlines key performance indicators that are acceptable and should be used as the area of performance improvement to move good and best practice. Good outlines key performance indicators that are considered acceptable performance for an organization that is seeking excellence to be used as an area of performance improvement to best practice. And then best practice are those KPIs that are considered to be the highest level for an organization thriving behavioral health care organization. This measure should be considered the gold standard of performance. So things like, what percentage of individuals served successfully completed an episode of care? What percentage of our staff are meeting the competency requirements to fidelity on an evidence-based practice? What is our engagement rate? See, meeting the 9 core competencies is how provider organizations can operationalize the elements of best practice to achieve value and financial viability. Operationalizing the administrative and business best practices is key to accomplishing the quadruple aim as set forth by the Institute of Healthcare Improvement, which includes population health, patient and consumer experience of care, lower per capita cost to payers, and improving the well-being of the care team. The core competencies described today are rooted in an approach that supports the value-based environment and the quadruple aim through operationalizing administrative and business best practices to support recovery and resiliency. To successfully open, operate, and maintain a behavioral healthcare organization, it's essential to understand and embrace these core competencies. So what is the leadership's role in ensuring direct service value? Well, some of the key concepts that we put together is financial viability and sustainability of the organization is one of the overarching responsibilities of leadership. The mission and margin are interdependent. Financial viability goes beyond the balance sheet. It incorporates both evidence-based clinical practices and evidence-based management practices to continue to serve the organization's communities. As payers move away from traditional grant-based funding and implemented fee-for-service, managed care, and alternative payment models in that value-based environment, many organizations will need to adapt their workflows and day-to-day operations to support the new payer requirements. These new workflows will both require clinical and administrative changes for the organization to remain viable. So the first is, how do we motivate our teams to peak performance? See, the amount of reinforcement needed to keep people focused on their work is relative to the amount of reinforcement actually available in the environment. So here's a poll question for you, team, and feel free to put your responses in the chat box. Does your organization have established productivity standards, yes or no? So we're seeing yes pop up in the chat. Well, let me take that question a little bit further, since everybody seems to have a yes. What percentage of your teams do you actually think are meeting and exceeding those expectations monthly? 20 to 40, 40 to 60, 60 to 80, 80 or higher, or you don't know? So quite a few A's, B's, and C's. A, but only the lower end of the A. So the question is, if we're in the A and B category, how are we making budget? How are we sustaining the organization? See, the goal would be we would be 90% or higher of team members meeting or exceeding the current direct service requirements. So when we define productivity, how did we come up with that number? Well, we start off with how many hours are available. How many hours do you need delivered for your contracts? How many hours do you need delivered to meet your financial needs of the organization? But also, what's the treatment plan tell you? I was working with a team several years ago, and I remember the CFO talking to the leadership team and saying, if we just provided the services that were ordered on the treatment plan, we would have a $3.2 million margin this year. Think about that. If we just provided the services that were on the treatment plan, they would have a positive bottom line. Remember, productivity is not a measure of how hard our staff is working, but a measure of how the system is supporting them. So think about schedule management, redundant processes, things that we put in their way, but they're not successful. But minimally, we want to think about, 60 to 65% of available time. This is 65% of 1352 hours a year, or 26 direct service hours a week, 5.2 billable hours a day. Documentation turned in within 24 hours and high levels of customer service. That would be the minimum sample expectation in my job description. So breaking it down to help staff be successful, well, I've got 1.25 months of PTO. I've got 0.32 months of holiday, or 56 hours. I've got 7.58 months that I actually are spending with individuals. Another 2.85 months that I don't have to be billable, which gives me my 2080 for the year. So to find the productivity, the organization will start with their actual cost of service and develop kind of the productivity expectations to think about, what do I need to do to meet our financial obligations? The minimum national average of service is between that 60-65% of paid time, with the higher end of that being 1352 direct service billable hours a year for a full-time staff member. And even having expectations for manager supervisors, depending on the number of people I supervise. So the clinical percentage of service capacity, if I supervise 1 to 3 people, my expectation as a leader would be to have 80% of the direct service staff's expectation. If I supervise 4 to 6, I'd be at 70, 7 to 9, 60, 10 or more, I'm at 50% of the standard. So it'd be 80, 70, 60, 50% of that 1352. Even executive team having a 0 to 10%. When I was CEO of my old organization, I had the expectation of 0 to 10%, where I would do an emergency services and perhaps an intake, some prevention education work in the community, things that I would get productivity for. But depending on the culture, the fewer distractions in the workplace, it takes very little to keep people on task. If there's a lot of distractions available, it'll take a lot of reinforcement to keep people focused. So what motivates your team? One of the best ways that I found to motivate team is to really think about supervision, the role of supervision. So here's a sample supervision log that I can look at the administrative tasks, the housekeeping tasks that I need to review with you on a weekly basis. So I'm going to check box things at the top, your assessments, your treatment plan, your direct service standards, your no-show rates. And then what do we need to do specifically to help the individuals get up to speed? What are the individual systemic barriers? Well, we can see that this particular team member increased service hours by 2 additional hours per day and schedule 34 to 38 hours client hours a week to hit my 26 based on my current no-show rate. And the same thing can be true for the group supervision form. That if I'm having team or group supervision, one of the things to think about here is, remember, when I'm providing group or team-based supervision, we always want to praise in public and correct in private. So here's where I'm going over the team's performance, not necessarily an individual team member's performance. So by having that direct and focused feedback, I can help coach staff to optimal performance. And once the direct service requirements have been established, the organization should review our unrealized service capacity on a monthly basis by staff member, by program. The unrealized service capacity calculates the unrealized service capacity of teams or programs and the potential lost revenue due to underperformance. And this is a key management report for reviewing viability and forecasting potential margins. So here I can see my outpatient staff. The goal is 113 hours a month. I have 45 clinical FTEs. On average, they're hitting about 57 of the 113. So they're running a little less. They're running about 33%. So those of you that are in that A and B category, this is that level of performance, which tells me that if the 45 staff are unable to deliver their 113 hours a month, we're going to leave about 30,132 hours undelivered this year. At an average reimbursement rate of $115 an hour, that's $3.4 million in unrealized revenue. I want you to think about that for a moment. So staff are producing around 33% out of a goal of 65. I have unrealized capacity of over 30,000 hours that will be undelivered this year. Unrealized capacity with our team members about 22.2 FTEs. So the opportunity is, if we got people to goal, we'd have another $3.4 million in the outpatient program. What would you like to do with another $3.4 million in your program? How about hiring those additional staff members? Maybe giving some raises. So think about action plans and operating procedures to align clinical performance, value, and financial performance. Here's the manager's role: to review staff performance weekly against agency-defined clinical targets and that value-based environments. As part of that supervision management time, is determine the reasons for the variance. Is it no-shows, cancels, white space in the schedule, block time? The reasons for underperformance may be attributed to unskilled staff who've not been trained adequately to engage and provide services to meet the clinical needs on their caseloads, high no-show rates, consumer cancel, staff cancel rates, low caseload size, mismanagement of the schedule, just to name a few. And if staff are meeting and exceeding their organization goals, we should consider an incentive plan for them. If the organization puts into place a financial incentive plan, the organization must also put into place a string of quality assurance and corporate compliance plans to ensure that the agency does not engage in fraudulent or illegal activities. So if I'm going to get a merit increase, if I'm a clinician, then let's say that 3% increase would be 65% productivity for the year, 100% utilization management, utilization review, and 90% documentation completion. Managers' raises will be based on their staff's performance. You can see that here, the clinicians and the managers have the ability to earn anywhere from a 0 to a 5% increase this year based on their performance. The higher the performance, the more of a raise. The lower the performance, less of a raise. And the same thing with prevention or support staff, that we can actually set up merit increases for those team members. But the only revenue that may be coming in might just be around the clinical outpatient team. Those episodes of care, those per member per month, or those other opportunities to earn additional revenue. See, develop and implement direct service productivity expectations, but to begin with the cost per staff member. So I have their salary plus their fringe plus the overhead equals the cost, the total cost by staff member. But a lot of our costing work that's done by Scott Lloyd from our team, the president of MTM, is to determine the cost by staff hour based on productivity expectation, not hours worked. By dividing it by 2080, that's a false assumption. So I want to know at least my cost by staff member. Then I can go and start even looking at my cost by CPT, HCPCS, and provider type. Based on the cost of the staff member per hour can be determined if the direct service hour requirement is acceptable to meet our costs. So as we said earlier, the example I showed earlier about that $3.4 million, the average revenue per clinician, if their meeting goal, would be about $80,000 per clinician if they're at or above goal. Then that's $3.4 million directly to your bottom line. If I'm not at goal, then that $3.4 million, let's say in a value-based or episode of care, even a PPS environment, that becomes $3.4 million of cost, not revenue. Even in some capitated environments that we've seen across the country, that might be kind of what we call maintenance of effort, in which the payer is going to come in and say, well, we've given you $3.4 million, but you didn't earn it. So therefore, we're going to make some adjustments in next year's contract. So one of the things that we work with teams in my work with them around productivity management, we start thinking about, what's that margin? So it's 65% productivity with a 35% no-show rate. If they're at goal, if my average revenue is $115 an hour, my cost per unit is $59.02. I'm making $56.22 every time I provide an hour of service. But watch what happens to my margin if I'm underperforming. So if I'm at 33% productivity, then I'm losing $26.26 every time they provide. So if I'm not performing up to goal, or the net revenue is low due to write-off, bad debt, et cetera, then the scenario below is if the actual direct cost of service hours is 33% of paid time, or 686 hours a year, then the provider has a negative margin per every service hour provided and loses $35,503 per full-time staff member. If the organization has 45 staff members, that's an operational loss of $1.5 million. So you can see how in reviewing productivity, and even in a value-based environment, we're aligning cost and value and outcome. And it's important for the direct care staff to understand the rationale for their direct service hour targets. Not only are these designed to meet the financial needs of the organization, but also the clinical needs of those individuals in care. By reviewing the caseload and the staff member in supervision, service intensity and duration can be based on the assessed needs of the consumer. Caseload size and medical necessity will drive the amount and scope of services that are in care. The higher my functionality, the less service I should receive. The lower my functionality or the greater my need, the more service I will need. So the higher intensity, I might have a lower caseload in order to provide the adequate amount of service to meet the client's needs. So some of the things that we think about that might be detractors or enhancers impacting the value of direct service is something that I used years ago of an Ishikawa diagram regarding clinical productivity. So you can see that the top and the bottom here, the top is things that support productivity. The bottom is what detracts from productivity. So our charts pulled, electronically and connectivity. Do I have connectivity to electronic record? So there's documentation efficiencies, internal communication efficiencies, work ethics, information technology, service coordination, billing, value-based contracts, unfunded mandates, staff retention, or maybe some of the things that we want to look at. And are they supporting productivity or are they detracting from productivity? So things like lack of clear, consistent authority granted, lack of space to provide my service, lack of accountability, unnecessary internal meetings, staff morale, poor time management. Staff shortages would be one of those things that would detract towards productivity. But enhanced productivity would be greater time management. Go to organizational skills, creativity, connectivity, the electronic health record, superior schedule management. So think about if you were to do this chart, what would your supporting elements in your practice to help support direct care? What are the things that keep your staff detracted, or the system noise that keeps them distracted from meeting their client needs? But then also, not only we're looking at clinicians, but we're also looking at maybe those enhancers for direct service staff. So things that would help our support team. Do I need a new check-in window, client relationship training, efficiency expert to evaluate the client, integrated computer systems, electronic health records, documentation better identified up front, or those detractors that we might see. Misplaced files, trusts, all kinds of organizational quality backup coverage, customer service issues, scheduling errors, telephone screenings, things that keep our support team detracted from assisting our clinicians in meeting the direct service requirements. So as we think about this as a performance improvement opportunity, what are the administrative or non-direct care impact, and what would be the clinical enhancers or detractors to direct service to enhance volume? So again, our measures are based on best practices from around the country. So best practice measures are a set of 100% to ensure that the reference standards happen in the time that's fundamental to corporate compliance and safety. So thinking through these expectations, 100% best practice would be 100% of staff will meet their direct service hours 100% of the time. Leadership will implement performance coaching and management to assist staff in meeting direct service hours 100% of the time. Leadership will ensure financial viability through financial recovery planning, should analyze projections fall 5% below revenue targets. How do we need to rebalance our cost and service delivery? Leadership will present a balanced budget for board approval with performance assumptions 100% of the time. The Chief Financial Officer will forecast revenues and expenses monthly and alert senior leadership of any shifts greater than 5% below target 100% of the time. That's best practice. Other things we might think in there is on the support side is that failed denied claims are reviewed prior to service delivery, that avoidable denials should not exceed 1%. If I do have a failed claim or activity, that's re-adjudicated, rebuilt, and corrected within 24 hours. So not only do we have KPIs for our clinical team members, but we also have KPIs for our support team professionals. Good practice is that 90% of staff are meeting their targets 95% of the time. Leadership will implement performance coaching and management to assist staff to meet their direct service targets 95% of the time. Financial viability is projections below 7%. And then we go to baseline of 85% of staff will meet targets 90% of the time. That's baseline. That's what I need just to keep the doors open. Leadership will implement performance coaching to assist staff in meeting the direct service targets 85% of the time. Leadership will ensure financial viability through financial recovery plan that should be analyzed. Projections fall below 10% of revenue targets. The Chief Financial Officer will forecast revenues and expenses monthly and alert senior management of any shifts greater than 10% below target 100% of the time. So baseline, good, and best. Where are you at? What is your baseline? What is your best? I want to be able to open it up for some questions, team. Feel free to open up your mic and ask a question, or if you have a question, please feel free to put it in the chat. When you think about creating the balance between value and volume, can you see the connection of how direct service activity enhances value? The lower the direct service, the higher my cost, which detracts from value. So if you want to raise your hand, team, I can call on you, or feel free to put your question in the chat. So Lisa, good to see you, but I think you have a good question. Why do so many of us struggle with this? When you were at NACON, so many agencies from all over the country talked about not holding staff accountable. Well, what we've heard about the not holding staff accountable, I think sometimes, Lisa, some leaders are reluctant to hold staff accountable, especially over the last year or so, because if they leave, then there's no one to replace them. And that's where you go back to the unrealized service capacity. And so think about that expectation. Let me go back to that slide. So here, if I look at the slide of I have 22 FTEs in unrealized capacity, if I were holding those 22 people accountable and they left, it would be okay. So think about, if I've got the expectation here where I'm now losing 35,000 on every staff member, not making 59,000 or 80,000 per staff member. For every outpatient clinician, direct service provider, we should be making at least a 50% margin. I think one of the issues is that we've not necessarily trained our managers to help support staff. Coaching them up in the organization is something I work with teams all across the country, Lisa, and help coaching staff up to optimal performance. So helping prepare the managers to help prepare their staff to meet the needs of their consumer population. One of the other questions in the chat that came in is like, what about training time? Well, you can see, you know, when you think about, I can go back to that example. And so that I still have 2.85 months of the year in non-billable time. That's where supervision and training would happen. So I still have 456 hours for training. So I don't back out training. And so this would be 60 to 65% of paid time, available time. So understaffed paid. So I pay you for 2080, 60% of that, or 1352, should be on the benefit of our consumers and families that we work with. That gives me 7.5 months of the year to be billable. And that 7.5 months of the year in billable time results in 4.2 months of the year that I do not have to be billable. That's when I have my annual leave, my PTO, my supervision, paperwork, travel. So Nicole, you say, I feel lower caseloads can contribute to lower productivity rates, which is largely due to serving unfunded and underfunded clients that don't want to rack up a bill. I think one of the things here is that if I have a lower caseload, then I should be providing more service, not less service. So the expectation is, 26 direct service hours a week. If I've got 10 people on my caseload due to their intensity, then every person on my caseload should get 2.6 hours a week of care. That could be individual, group, or other skill building work. And Miranda says the other caseloads that too high lowers productivity. That may be the case because you have folks, I want to go in and look at those clients and not haven't been seen in 30, 60, 90 days. When we actually go in and do this work, it's like I talk to clinicians all the time and they say, well, I have 120 people on my caseload. Well, are they carrying cases for the prescribers? And I'm only seeing them once a quarter to update the treatment plan. I recommend that we change that practice right away and move either a case manager in med services or the nurse or the physician themselves or the APRN can do the treatment plan if I'm meds only. In addition to that, who hasn't been seen in 30, 60, 90 days? What's the definition of an active caseload? Would be those people that are getting care in accordance with their treatment plan. If it says I'm only getting service once a month, and we actually have caseload calculators that we can work with you on this, Miranda, where we can actually go in and say, based on how many the caseload expectation, is it weekly, bi-weekly, monthly, based on where I'm at in my level of care or my clinical progress, then so if I'm seeing a lot of people monthly, then I should have a higher caseload. If it's a combination of weekly, bi-weekly, monthly, then the sweet spot that I've seen for clinicians to be successful in meeting that 65% is about 60 to 65 staff members. And there was another question to maybe go back to the prevention slide. So if we think about prevention staff members, the expectation is they must be 100% productive, because everything prevention education staff do is charged off to the grant. And so if I'm meeting 100% of my grant deliverables, I would get a 3% raise. I get 2% manager discretion, or less than 2%, if I'm not meeting grant expectations or manager discretion. But realizing that usually the prevention education funds are fixed, so any additional revenues for any other staff, whether it's prevention, education, support, or leadership, is coming out of your outpatient program. So am I getting those bonus payments? I remember in one particular state, they were providing bonus payments if the providers were able to secure and deliver 3 clinical events of service per month after intake. So if I had 3 initial visits the first month, I got a bonus payment. Why? Because the managed care company realized that after 3 visits, if you engaged me, I'm gonna finish my course of treatment. Anything less than 3 services that initial month, I'm more likely to drop out of care or increase the no-show rate. So think about that engagement rate that we talked about earlier. What percentage of clients are actually engaging in treatment? See, clients will show if they find value, which is also why I do a lot of collaborative documentation training, where the individual served and the clinician write that treatment summary at the end of our work together that demonstrates the goal we worked on today, the intervention that we provided, the individual's response to our intervention, the progress they're making, and the plan for next week. If I leave that office today, or that telehealth visit or community in-home visit, knowing how I'm doing and what my next steps are, I'm more likely to continue to be engaged in the services that we provide and follow through with specific course of treatment. All right, so Florence, you have a question. Are you saying that psychiatrists that provide collaborative care services by advising, consulting with primary care doctor have a caseload of 70 to 80 patients per month? No, it would be higher than that per month for your prescribers, which means behavioral specialists is providing less care. The psychiatrist is offsite and does not see patients in person. So most prescribers are remote these days, and for the prescriber, we usually see a direct service ratio of about 70 to 75% of paid time must be in direct care. So, which means based on that percentage, if I do some quick math here, if I go 2080 times 70%, so that'd be 1456 a year divided by 12, which would be 121 hours a month divided by 15. So if I go 121 times, let's say 2, so that'd be about 242 patients a month seen by the prescriber or higher, depending on if it's a half hour, 20-minute, or 15-minute med check. So if I have 121 a month divided by 20 days in the month, so that'd be 6 to 7 hours a day divided by, let's say, 0.25. So if it's a 15-minute med check, so you're going to have about 24, let's say 27 to 32 patients a day in the prescriber's schedule, if it's a 15-minute or 10-minute med check. If the appointments are longer than that, then the scheduling becomes different. So when you think about the schedule rate, what's needed to help support that professional based on the no-show rate. So if I have a no-show rate of 20, 30%, I need to schedule 34 to 38 client face-to-face hours a week to get my goal of 26. If I'm only scheduling to goal, I will never be successful in meeting the direct service requirement. So value is about, is the individual being served getting value of the service as well? And so if we're treating to target, really moving towards team-based care, then the individual is getting the scope and duration of service they need based on their functionality, which would define the dosing of services and the length of stay. What other thoughts or questions do you have, team? What were some of your takeaways from today? Tell me one thing you learned today. So Jeanette says we have work to do. And Misty, you're saying trying to learn the baseline good and best practice model and working to get even a solid baseline. So I think, getting to those baselines, and I agree with you, Missy, that staff turnover has really hurt baseline because you got more folks scrambling. And I think you're right, Jenning, is the importance of holding folks accountable, but also celebrating and being able to motivate supervisors to have more oversight of their staff. I would agree, Sharon. We'd like to thank you all for attending today's webinar. If we can be of further assistance, please feel free to reach out to us. We're happy to help in any way we can. Thank you, everybody.